Good afternoon to all. Happy to see you again. So today we are going to learn about gastrointestinal symptoms part 1. So that is on nausea and vomiting, constipation. So next week there will be a continuing session on this same system, that is on intestinal obstruction. So today we have eminent faculty joined with us, Dr. Sarita Singh. She is basically she is an anesthetist, and also she is a cardiac physician. And now she did her foundation course and the 6-week certificate course from Pallium India, and also she did her fellowship in palliative medicine from Calicut. And she has a lot of years of experience in palliative care. She is coordinating the certificate course in essentials of palliative care, and by Indian Association of Palliative Care, she is coordinating that program also. She written a book on pain and cancer management, and she has received that now more than that awards, and more than 15 awards and recognition. And she is a well-versed person in this field. Dr. Saritha, welcome and over to you.
Thank you, Shiva Madam. Good afternoon, everyone. So today's topic is nausea and vomiting, which is very important of palliative medicine, and we are seeing a lot of patients who are suffering with nausea, vomiting. This is very intractable and very problematic situations in patients as well as their attendants also. So today we are going very short. Nausea, what is nausea, vomiting and retching, how we can manage these patients in the palliative setup with minimal resources. So I can share my slides.
I have to share it from my end.
Yeah.
Just 1 moment.
So about 50 to 60% of patients with advanced cancer, they are suffering nausea and vomiting in many circumstances. The patients and the caregiver, both physically and emotionally, are get affected. Nausea and vomiting, nausea and vomiting can increase the physical, psychological, and social problems in force. So it increases the problems associated with physical, psychological, and social problems. Next. The nurse's role in the management of nausea and vomiting requires excellent assessment, skills, and knowledge of physiology, current pharmacology, and the pharmacological interventions. So the little bit knowledge should be to the nurses about the pharmacology of the normal pharmacology of the management of nausea and vomiting. And you should know also what is the situation of the patient at that time of the nausea and vomiting. So very simple assessment should be there at your end. Next. So what is nausea? Nausea is an unpleasant feeling of the need to vomit, often accompanied by pallor, sweat, salivation, and tachycardia. Nausea is an unpleasant feeling to vomit, to need to vomit, but vomiting is not there. Means some food expulsion from the mouth is not there, but there is feeling of nausea. Means something nauseating, something unpleasant feeling is the nausea. It occurs in 40 to 70% in the patients of cancer or suffering with cancer, and 20 to 50% on other terminal chronic diseases like AIDS, chronic kidney disease, and CHF. These patients also showing the feeling of nausea. They affect patients' daily functioning and quality of life much. The feeling of nausea, vomiting, and retching affect the quality of life of patients as well as their caregivers also. Active palliative management is important and it can be controlled in 90% of patients. So we should think that these are the symptoms which we can control by the palliative care, and they can be cured in approximately 80 to 90% of the patients, and we can improve their quality of life by controlling these intractable symptoms. Next. And what is vomiting? There is difference between nausea and vomiting, though you should know the difference between the nausea and the vomiting. Vomiting is the forceful expulsion of the gastric content through the mouth. When any content comes out through the mouth, this is the vomiting. But the content, when the content is not coming out through the mouth, but there is feeling to tend to come out the content through the mouth, is the nausea. So there is a difference between the content. When the content is coming out through the mouth, it is vomiting, and when the content is not coming out through the mouth, but there is feeling of that it will come out, so this is nausea. It is with association of the vomiting is sometimes associated with pain, aggravated pain, and the patients who is doing vomiting is he can refuse to eat, he can refuse. These are the associated features. Those who can relate that the patient is complaining or the patient is showing that this is vomit. And what is retching? Retching is the muscular activity of the abdomen and thorax, often voluntarily to inspiration against a closed mouth and glottis without discharge of the gastric content. So retching is a forceful movement which comes through the gut towards the mouth, but there is nothing to come out through the mouth. So there are minute difference between the nausea, vomiting, and retching. You should know the difference about the nausea, vomiting, and retching. Next. This is the pathophysiology of the vomiting. There are many centers, many centers who influence or who aggravate the vomiting center or stimulate the vomiting center, and by stimulating the vomiting center, the vomiting occurs. These are the pathophysiology like causes like cerebral cortex and the GI causes, vestibular causes, and the trigger zone, the stimulations, the stimulator which stimulates the trigger zone. So these are the zones when they get stimulated, they cause the vomiting. They stimulate the vomiting center, which is situated in the brain, medulla of the brain, and they cause the vomiting. So I will not go in detail about the mechanism, but you should know the basics that how the vomiting occurs. Next. These are the main drugs which we are using in the nausea and vomiting. They act on the receptors and they are receptor antagonists. Basically, you should know the name. That is the most common. We are using haloperidol, which is dopamine antagonist, and H1 receptor blockers, in which we are commonly using the phenargan. And in acetylcholine antagonist, the scopolamine, which is not available, we are using in place of this acetylcholine antagonist other drugs. The serotonin antagonist like ondansetron, which is most common drug, which we are using in the palliative setup. Then substance P and receptor antagonist, that is aprepitant. Aprepitant is mostly used in the malignant bowel syndrome, which is very costly and not easily available, but sometimes we are using aprepitant. Next. The other common drugs are the prokinetic agents like perinorm or metaclopramide, which we are using very commonly in the patients of the cancer who are getting morphine, other vomiting or nausea for having, and other useful agents like steroids. We are also using steroids in the last. Next. As an adjuvant or as supportive drugs. These are the some clues by which you can guess that the basic cause of the nausea or vomiting. That is when the impaired gastric is there, then how you will diagnose that patient is having impaired gastric pain. These are the causes like intermittent nausea with early satiety, postprandial illness or the bloating, nausea relieved with vomiting small amounts of the undigested food. When you find these features, then you can guess that this is gastric. Then if there is vomiting due to obstruction, then what question you will ask? In the obstruction, there is intermittent nausea with cramping. When you feel the patient is complaining that sometimes I feel nausea with the cramps or cramping pain in the abdomen, then and nausea relieved with the large emesis sometimes. This is the feature of the obstruction of the bowel. Then you can guess that is the underlying cause is the bowel. When the vomiting is caused by the chemical substance, then we'll see the persistent nausea aggravated by the sight, smell of the food, or it is unrelieved by vomiting. So this is chemical cause. Chemical cause is very important. When the toxins are present in the body, they can stimulate the vomiting center and the vomiting is persisting. So these are the small ideas, clues by which you can search the underlying, you can think the underlying cause of the vomiting or nausea. Next. When these are others like increased intracranial pressure, this can also cause vomiting. How you will diagnose, how you will search that this is due to increased intracranial pressure, early morning nausea and vomiting associated with headache. When you will find that patient is having early morning nausea and vomiting, which is associated with headache, then you should think about that means there is intracranial pressure is increased, maybe the bone mates, maybe due to the tumor, or but basic cause is increased intracranial pressure. If there is vestibular component, then nausea is aggravated by the movement. Sometimes you have felt that by moving on sitting bus, traveling during the traveling, the vestibular component aggravated and the nausea and vomiting. The person can feel nausea and vomiting by the aggravating of the vestibular component. The cortical component, nausea and vomiting associated with the anxiety. This is related with the cerebral cortex mechanism, and in which sometimes I have seen many patients, they have vomiting due to the anxiety, ghabrahat. They have anxiety and they present as a vomiting. So these are the important features by which you can reach the up to the origin of the cause of the vomiting. So when you will find the cause of the vomiting, you treat the patient very likely. Next slide. Assessment for the nurses, we think that your assessment should be as मीन्स ऐसा होना चाहिए कि जैसे आप जल्दी से पेशेंट को एसेस कर लो by asking some questions like onset, when did it begin. The assessment of the vomiting is just like the assessment of the pain, by which you can reach up to a mark, up to a level of the uh, origin of the vomiting and nausea, and you can reach up to the treatment, what treatment you should give to the patient. So these are the points under which you can ask the question: onset, when does it last, and how often does it occur? So I have shown in the last slide, these are the causes. These are the that were the important cause. We'll search that cause according to your this assessment questions, like palliative or provocating features. What makes it better? What makes it relieve or worse? Then quality. What does it feel like? How can describe it? Then radiating. If you have nausea with or without vomiting. Next. Can ask the severity. What is the intensity of the symptom? You can keep it on the scale also. And treatment, what medication and treatment currently is, if the vomiting is associated with drugs, then you can ask the past drug history of the patient. Impact, you will ask the impact, what do you believe causing these symptoms, or how is your symptoms affecting you and your family. Values, what is your comfort or acceptable level for these symptoms on a scale of 0 to 10? And are there any other way of feeling about these symptoms that are important to you? Or these are the important questions of the assessment, the status of the patients and their family, how the nausea and vomiting is affecting the patients as well as their caregivers. When you ask this question, you reach to your the management of the nausea and vomiting. Next. So the main causes of the nausea and vomiting are anxiety, pain, as I have told you earlier, intestinal obstruction, constipation, drugs, raised ICP, and others like abdominal carcinoma, extensive liver metastasis, ascites, hypercalcemia, uremia, like in chronic kidney failure patients. We are having very frequently nausea and vomiting in these patients. Next. You can remember these 11 M's. If you will remember these 11 M's, you will always know the causes of the vomiting, like metastasis, meningeal irritations, movement, mental anxiety, medications, mucosal irritations, mechanical obstructions, motility, metabolic, and infections, etc. Myocardial also. Uh, in myocardial infarction, there is a onset of vomiting. It's very frequently. So these are the important causes which I have already the related questions. You can find out the diagnosis almost. These are the questions. Next. The chemical causes, the most chemical causes in the patients of the cancer are the opioid, drug-induced, digoxin, anticonvulsant, antibiotics, cytotoxic. But in the cancer, when we are talking about the cancer patients, they mostly they are drug induced, like chemotherapy drugs. These patients are getting chemotherapy, so chemotherapy induced vomiting is very common. And the metabolic organ failure, like if the patient is having extensive disease goes into the organs and get metastasized, the organs failure, patient may go to the organ failure and can cause the vomiting, nausea, ketoacidosis, uremia, hypercalcemia. These are the conditions in which patient presents frequent vomiting and should prepare for the in these patients for the treatments and to relieve the symptoms. Chemotherapy agents are very pathogenic, and mostly our cancer patients are mostly on the chemotherapy drugs. So vomiting, nausea, vomiting is a very important features in the cancer and the palliative patients. Next. What treatment you will give in the drug-induced vomiting? So drug-induced vomiting, in radiotherapy, chemotherapy, the drug of choice is haloperidol. We can give 1.2, 0.5 milligram OD or PD depending upon the frequency of the vomiting. The chemotherapy-induced drug, the most favorable choice is ondansetron, 8 milligram stat or 4 milligram TDS, granisetron. These are the choice of drug in the chemotherapy-induced vomiting. If the vomiting is due to metabolic disorder or uremia, you can give metoclopramide and haloperidol. Ondansetron is also very important in the uremia and metabolic disorders. Next. So very important point, because all we are dealing the cancer patients with, we are frequently giving the morphine. Morphine is alone a cause of a vomiting in some patients. So initially, when you are going the morphine, add the anti-emetic drug. It is very important because many patients are complaining due to the morphine vomiting. So the drug of choice, we are using metoclopramide very frequently first line, but you can use haloperidol also. Haloperidol and the metoclopramide. So your prescription of the morphine should always be with the anti-emetic at initially 1 week of the starting. When the patient get accommodated with the vomiting, then you can stop the metoclopramide or the antiemetic. But one thing more is also important. Metoclopramide is also prokinetic drug, which also counteract the constipation in which is induced by the morphine. So we are using metoclopramide as a first drug of choice in the in the morphine-induced vomiting or morphine-induced. It helps in both way. It helps in the antiemetic as well as an anti-constipation also. So always use opioid antiemetic. Always use antiemetic with opioids initial days. Next, this is important for the palliative patients. Then gastrointestinal causes are gastric stasis, stretching or when there is stretching of the capsule of the organ due to the distension or due to the extension of the disease, this also cause the vomiting. Then serosal stretch, irritation, and liver mets, they are also responsible for the vomiting. Next, management. In the management, relieve the underlying cause. First, treat the underlying cause. Then the drug of choice is ondansetron. If but ondansetron can cause the constipation also. Be careful and treat constipation as well as treat the nausea and vomiting. Next, PPI you can add. So when prokinetic or metachlorpropamide is indicated, promote gastric emptying. So the first work of the metachlorpropamide is also increases the gastric motility as well as antiemetic. When you have to give metachlor, when stasis, I am talking about the gastric status. When there is partial gastric status, then you can use the metachlorpropamide. If there is complete obstruction, you never use the metachlorpropamide because it increases the gastric motility, and in the complete obstruction, when you will use the metachlorpropamide, it will increase the forceful movement of the intestine, and intestine may be burst out, or there is some perforation may occur. So this is contraindicated in the complete intestinal obstruction. If there is vomiting due to complete intestinal obstruction, never use metachlorpropamide. Next. So cranial causes, the cranial cause increased cerebral edema, intracranial tumor, any metastasis, if they, anywhere, anyhow, if there is increased ICP, then it can cause the vomiting. Especially these type of patient can produce vomiting in the morning time. Next. The treatment of choice is dexamethasone. We are using in high doses dexamethasone. And if ICP raised due to radiotherapy, we are using mannitol, etc. The most common is the steroids in the raised ICT. Next. Other causes, movement associated like vestibular stimulation, anxiety induced, or anticipatory emesis. Sometimes patient feels that feeling of that immediate he is going to vomit, but not actually happens. So this is anticipatory emesis. This also can cause the nausea and vomiting. Next, these patients need the psychological support. Management, treat underlying cause of by the NG aspiration, benzodiazepines, and psychological techniques like relaxation and benzodiazepines. Direct stimulating of vomiting center. Etiologies, direct stimulating means tumor can stimulate the vomiting center and emotions can stimulate. The treatment is dexamethasone. Stimulation of the vomiting center is by various ways like CTZ stimulation, vestibular stimulation, GIT stimulation, brain stimulation. All these can stimulate the vomiting center which is present in the medulla of the brain. So these are the causative agents. Next. Vestibular, I have told you. Next. Is the patient still vomiting? If you have done a lot of things for the patient, but patient sometimes vomiting, they continue their vomiting. So what you will do then? Then with vomiting more than 2-3 times daily, then consider a syringe driver. Means if patient is not able to take orally and still vomiting is going on, then to give the drug parent. choose a route of the administration the ensure that drug reaches at the site of the action. This is often exclude the oral route. Titrate the dose carefully. This is titration of the drugs when from the oral to the IV when the patient is not able to take oral and thing is still persisting. So thing is more intractable and drastic symptoms. You have to you have to change your route of the drug and relieve the patient as early as possible. Next. Is vomiting due to opioids or chemical metabolic? This I have told already. Choose your drug and give the patient and relieve the vomiting the patient. Next. As nursing care, you should advise nutritional advice and diet advice you can give to the patient for the support, you can advise like eat small frequent meals in meals rather than 3 large meals, and try consuming foods during the time of the day, take the night. Many people find the breakfast time is best. So according to the patients and according to their symptoms, you can advise the patients nutritional wise. Avoid fiber and avoid that carbonated drinks, cold or room temperature are better tolerated. How the patient can tolerate and how what the patient can accept easily to so in this way, as a nursing care, you can help the patient. Next, diet advice, make someone else to make food. If you are nauseated, this advice you can give the patient or their attendant. If the person is having difficulty in eating, is special diabetic or heart disease, that requirements can be relaxed and a dietitian can be counseled. You can take help from the dietitian, whatever the eatable and easily digestible should be patient, so that these cannot aggravate the symptoms of the nausea and vomiting. Cannot aggravate the nausea and vomiting. So what else we can do as a nurse? So keep your advise the patient cleaning about cleaning or maintaining of their oral hygiene and wearing of loose fitting clothes. Have maintain the hygiene so that there should be not any unpleasant smell which can stimulate the vomiting or nausea. So this you can help this way to the patients, and call your doctor when you feel that patient is having symptoms and not relieved and he's in trouble, so immediately call the doctor. Next. So what are the key points? Nausea and vomiting may be due to the primary disease or due to the secondaries or due to the drug induced or due to the chemotherapy. So it should be treated as early as possible. Symptoms should be relieved. And in the palliative care, our goal is to relieve the symptoms. So we have to. And the key to effective management of nausea and vomiting is a thorough assessment and the appropriate investigation or assessment of the patient's gravity of the vomiting. You should do. And what are the causative agent? Avoid these agent from the patient. And treatment should focus on the underlying cause rather symptoms based. First, if you will find out the underlying cause, you will treat the patient very nicely. Then where emesis limits antigenic drugs, then absorption parenteral route should be. If there is any gastric problem or if patient is not able to take orally, there is any bowel problem, then you change your route, the drug administration, and help the patient as possible. Thank you so much. Madam Shiba, if you want to add something, if I have left.
Yeah, ma'am. So can you please little bit talk about more that constipation too? So just a brief the constipation and that is also included in this session. Nausea, vomiting, and the constipation. So, if possible, you can do it today. Otherwise, you can add the next session, constipation.
Yes, I can add in the next session.
Okay. Yeah. Okay. Thank you, ma'am, for the presentation. Anybody need any clarification or any questions you have on this session, please ask her. Either you can unmute yourself and talk, or you can put your questions in the chat box. So I hope this session is clear to everyone. So before moving to the case presentation, I would like to highlight few things about the nausea and vomiting. So this is one of the most common symptoms in palliative care. So you all see these type of patients. When a patients come to you with nausea and vomiting, our duty is to identify the cause. You have to do the proper assessment. If you do the proper assessment, definitely we can plan better, and the patients will get a good quality of life. So so your assessment will be perfect. So you have to do the perfect assessment and identify the cause. So that is the one important thing you should do. So we all nurses, we are not an authorized person to prescribe drugs, but you can do the proper assessment. And after the medications, also you can do the that review also, whether they have developed any side effect, whether they have getting a good relief or that kind of satisfactory relief or not. You have to do the that reassessment, and so then that way if you do the proper assessment, you can communicate with your doctor, because the doctor sometimes doctor is busy there. You are the persons to spend more time with the patients. So that time if you assess properly, that reports goes to the doctor, and based on your report, that the doctor will do the reassessment, and maybe if the doctor think if will change the some changes is needed, definitely the changes will be there, so that the patients will get better. That is our idea. So our aim is to improve the quality of life of the patient and their family. So if you do it properly, definitely the patients will get good relief. And here also the importance of teamwork, how to keep it in mind. So alone we can't do anything. So we can give some psychological support. You can do the proper assessment and all. But so along with that, the patient need some pharmacological management also. That time that we need a doctor, and also if they have a psychosocial distress like anticipatory vomiting. So maybe after 2 days, the patients will be going for a next chemo. That the patients will be thinking today itself, okay, after that again I will develop vomiting. Because of that, the patients will get nausea. So that kind of thing, there the patient needs some counseling and psychosocial support. So that time the medical social, if the medical social worker the worker is available, that patient will support the person. So otherwise the nurses or doctors will give a psychosocial support or counseling to the patients. The patients will feel better after that. So our aim is to improve the quality of life. So for that, you can do the proper assessment and give a try for the non-pharmacological management first, and then go to the pharmacological management. Okay. Thank you. We have one questions received in the chat box. In vomiting, we don't give drugs by the oral route at all. Who said Mugisha? Mukisha Elijah said in vomiting. We agree for when the patient is vomiting, we don't give any oral drugs, but the patient is not able to take it. But in between there is a gap. Okay, so that time we will give if the patient is able to take the drug orally. So you can think about the rural settings. There is no home. The patient is in the home. Complaining of vomiting, there is no injection. So that time what you can do, you have to prescribe some medication. In between, there's some gap will be there. So that time the patients will take orally. That will help the patients. But the patient is in the hospital, definitely you can give an intravenous injections or subcutaneous injection. And on the other side, if there is an intestinal obstruction there, your oral medication is not at all work. Then you can think about intravenous or subcutaneous or rectal or wherever that route is available, you can do it. So the first aim is to control the symptoms through orally. So if the patient is take the medication through orally, you can try through oral first, and then you can think about the other routes too. Any other suggestion? That another question is, NG tube aspiration will be helpful in relieving severe vomiting symptom. Dr. Saritha, one question is there. Sujita is asking, a nasogastric tube aspiration will be helpful in relieving severe vomiting symptom.
If there is vomiting due to the full stomach, then you can relieve by NG tube. But if there is cause is another, then you can give the accordingly drug, anti-emetic drug to the patient. NG aspiration is not always helping the vomiting, because the cause is you should know the cause of the vomiting. NG tube is not a treatment, but this may be sometimes relieving procedure. But you should know the exact cause of the vomiting.
Yes, ma'am, I agree. And also in palliative care, we don't suggest NG tube feeding and NG tube aspiration. We always identify the cause and try to manage the underlying cause. So that way we can able to reduce the symptoms. Here in palliative care, we usually do the NG tube aspiration is if the patient is having an severe intestinal obstruction. So that time profuse the intestinal secretions will be there. That time the patient will vomit continuously. That is that time the final management is to put a NG tube and aspirate the excess intestinal contents. So that way, otherwise we don't suggest that nasogastric tube.
Yes, agree.
Any other question? So what about domperidone syrup? Ma'am, next question.
Domperidone syrup, if patient is taking orally and the treatment modality is domperidone syrup, you can use orally.
Okay. Suppository. I don't have any idea about that. Anybody have any experience on that, suppository or any other things?
Subcutaneous transfusion is advisable if the patient is needing. The need of the patient is that, like, patient is not able to take orally and patient is terminally ill. Yes. You can use subcutaneous infusion.
So subcutaneous transfusion, usually we in palliative care we prefer subcutaneous infusion, especially in case of severe nausea and vomiting and intestinal obstruction. There we usually use subcutaneous infusion. We use the continuous infusion through syringe driver. Better see if there is a continuous infusion they is going, definitely we can able to control their symptoms as soon as possible. So that that is why we give a subcutaneous infusion. And also, if the patient is willing to go home, we will send the patients to go home with syringe driver, because sometimes in the end of life care situation like intestinal obstruction, there if there is a that nausea and vomiting there, or that continuous profuse vomiting there, we usually put in that subcutaneous infusion and syringe driver, continuous infusion. But the same time the patient is willing to go home, maybe the patient wants to go home and diet there, so that kind of that request will be there. So at that time we send the patient to go home with the syringe driver, and then the patients will get, we usually train the caregivers how to operate the syringe drivers and how to that manage with the subcutaneous infusion and all. So that way they will manage. So this is one of the good method for the patients who are in rural settings, and maybe you can easily manage in home care settings too. So you can train the caregivers. So we have a detailed session on that subcutaneous infusion. That time we will know more about that. Okay.
There is one case discussion.
Yes, ma'am. We have one case presentation. Ms. Swastika will be presenting a patient story today. Swastika, so to you. Swastika, are you there?
Yes, ma'am.
Over to you.
You can start now.
Good afternoon, everyone. I, Swastika Pradhan, staff nurse of Namche District Hospital. I'm going to present a presentation on a patient whose diagnosis is chronic kidney disease. Age is 50 years, gender male, and diagnosis is chronic kidney disease stage 3. Now, moving towards present complaint. Now, nausea, vomiting, loss of appetite, swelling or edema of the lower limbs, urinary retention, muscle cramps, weakness. Coming towards the history of illness, patient was admitted on 14th April 2022 with a chief complaint of loss of appetite, vomiting, weakness, weight loss, and edema on the both limbs. Patient is known as known case of hypertension and under medication. After admitting, several tests were done and found KFT and serum electrolyte deranged and diagnosed CKD on 20th April 2022. Hemodialysis is advised as twice a week. Examination were done. In examination, found that conscious and oriented, temperature 98.3 degree Fahrenheit, pulse 90 beats per minute, respiration 20 beats per minute, BP 170 by 100 mmHg, SpO2 92% in RA, RBS 122 mg per dl, skin dry and discoloration, limbs edema on both limbs, genitourinary, distended abdomen, and eyes is puffiness, seen puffiness in both eyes. Treatment and significant investigation. Under KFT, there is a urea, creatinine, and serum uric acid. Urea 126 mg per dl, creatinine 6.54 mg per dl, serum uric acid 4.5 mg per dl, CBC HB 8 gram per dl, TLC 9 lakhs and 2,000, RBC 2.8 mg per dl, platelets 1.66 to 20 lakhs, serum electrolyte, serum sodium 148 mmol per liter, serum potassium 6.0 mmol per liter, serum chloride 160 mmol per liter. Medication, patient was under medication, tablet telmisartan 80 mg, 1 tablet OT for blood pressure, high blood pressure. Tablet Diator 5 mg, 1 tablet OT to reduce edema. Injection on them 4 mg IVBD to prevent vomiting. Injection Rantac 50 mg IVOD to reduce acidity. And coming towards the psychosocial aspects, patient is worried about self only, like fear of pain, anxiety and stress, upset and depressed, and financial problems. Main concerns are restoring KFT function, electrolyte imbalance, preventing from infection, dietary management, generalized weakness, management of complications. Summary. Coming towards the summary, patient is a 50 years old male, got admitted in the hospital with GIF, complaint of vomiting, loss of appetite, weakness, and edema on both limbs. Patient is conscious and oriented. Diagnosed CKD on April 2022. Hemodialysis is done twice a week. Now, points for discussion are what are the roles we can do as a palliative care for this patient? How can we support financial problem for the treatment? How can we give a psychological support?
Okay. Thank you, Swastika, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. So I think the case presentation is clear to everyone. We can move on to the discussion points. So we would like to hear from you all. If you have seen these type of patients in your settings, how will you manage, and so how will you support this patient? So please put your, yes.
I have to give answer.
No, they will, so Adim, first they will share their thoughts and then we will conclude.
Okay. How we can support the patient as palliative care?
So please contribute your suggestions. Please put your thoughts in the chat box, or you can unmute yourself and talk. We need to help Sister Swadika. So she needs to help this patient. So her question is, what are the role we can do as a palliative care for this patient? And how can we support financially for this patient? And also her third question is, how can we give psychological support to this patient? Now we all know how to what is palliative care, and who needs palliative care, and how to communicate the patient, and how to manage pain. All those things we already learned. So please think about this patient and then put your suggestion. So Mukisha said, encourage eating in small bits and another ways for improving appetite. Okay. Offer ongoing psychological support through counselor or social workers. Okay. Along with the dialysis, needs to treat symptomatically for loss of appetite and vomiting. Very good. Psychological sound is it, psychological support and total care. Definitely this patient needs total care, physical care, emotional care, social care and spiritual care. So total care is we all accept. Okay, this patient need total care. Okay. Okay, ma'am. Carry on.
Me?
Yeah, yes. They will share.
Yes.
Yeah.
The palliative care for this patient, palliative care support is very important because we have to see the physical symptoms, his physical symptoms, emotional, financial, spiritual, all these involved in these patients. Physically is having loss of appetite, lower limb edema. So loss of appetite, the students has given the answer. Then you can give the small bits of the foods and some digestive enzyme you can add this patient to increase the appetite. But the most important thing is that this is metabolic organ failure system involved in this patient. But the patient is such a young 50-year-old male. He is having that type of situation. So in the emotion, he needs emotional support also in the form of that you have to encourage the patient for their disease or their treatment, because these type of patients, you will, when you will encourage the patient, the cope-up system of the patients will increase. Of the from the disease will increase. And social problem, the social problem, maybe this patient need the I think we have to think about the kidney donor also. We can educate the family members or their relatives to think about this point, on this point also. And financial support, you have to give some address of the NGOs who are there are many NGOs who are working for the kidney patient, and the financial support you can give them their address, or you can give them direction. And of course the hemodialysis is taking 2 times in the week. So hemodialysis itself is very expensive. So we can reduce the drugs, we can think about that. And spiritual support, listen the patient and their family, and encourage them. And of course there is a fear of death, so you have to listen the patient and counsel psychologically, spiritually. And
Okay, as ma'am said, we can support the patient spiritually also. Here, there is a 50-year-old man admitted with CKD. The problem is on hemodialysis. I would like to know whether he is in the hospital right now or he is in the home. Sister Swastika?
Yes, ma'am.
Yeah. Now he is in the hospital or in home?
He is in home.
In home. Okay. So now he is in home.
Ma'am, we are in OPD.
Oh, okay. So what you can do is you can make a telephonic conversation. You can call the patient and talk to him over the phone. So that way we can provide some kind of support, because he might be thinking like, okay, so somebody is there for me to hear my worries and all. So if you contact, at least if you contact through phone and ask him, so he feel much better. And after that, what you can do is you can find a local volunteers. So now he's in home. Nobody is there. The family members will be busy there, so nobody is there to talk to him. And if someone's nearby there, so they will go there and talk to him, and so that he can explore his concerns and emotions with the volunteers or any palliative care professionals there. You can connect with them, so that we can relieve some sort of that problem. Because if they have a psychosocial distress there, if they don't have anyone to share, so definitely the symptoms will increase, because the physical distress will be increased. So nobody, if there is no one listen their concerns. So you better you can think about a palliative care. If there is an nearby in any NGOs will be providing palliative care there, you can connect with the that particular organization. That through that the patients will get some palliative care support. Okay. So that way we can support, and also you can think about the financial. These patients need a lot of financial that help. So you can think about the connect with an NGO or small fundraising activities, so that we can collect a few some amount and help the patient. So you can think about think like that also. And what about the family?
He has one son who works in a private company as an employee, private employee.
Okay. Okay. So his wife.
uh, his wife died in 2019.
Oh, okay, okay. So here he lost his wife also. So nobody's. You can just put yourself into their shoes. You can think about from his side. So nobody is there. He has one son. He is working. Nobody is there. He is alone. So he lot of problems. Nobody is there. And sometimes neighbors will be there. Sometimes relatives come there and say hello and go. When so that kind of things will be there here. So this patient is completely on isolation. So I think if you connect, if possible, you can connect with an NGO. If the palliative care NGO there, you can connect with them, so that the patient will get some sort of support. What about others? If anybody wants to add anything, any other thoughts or any suggestions for this patient? Uh, so Swastika, the question is to you only. Do you have any that maybe friends support group in that area? These kind of support groups, do you have?
Now, I don't know any nearby Namji. I'll see it.
Okay. So, Sansan, she said there is no support group like this. So she needs to find out whether there is any support group or any NGOs nearby the patient there. So better if she find any groups nearby, definitely she will connect with that, connect this patient with that group. She has agreed. Yeah,
What was
ma'am.
the earning of the patient?
Yeah.
How he was working, retired something, some government job, or
No,
how
ma'am,
he was?
he was a farmer,
Okay.
and his son earns approx 15,000 monthly, doing overtime job.
So, Swastika, then what about his treatment? That financial help and all, who will help?
For this timing, his son is only helping him.
Oh, son. Okay. Okay. So, and also you have to talk to the son, talk to his son also. Okay. You have to listen his worries too. So he has to, maybe lot of problems will be there. He wants to look after his father, and he needs to work with a company, and in between there are a lot of problems. At the same time, like some guilt feeling is also there because not able to fulfill his wish completely because of his busy work and all. He needs to find money. Because of that, he needs to work, because so that will be affecting the patient also. So we need to listen both sides, patient side and son side, because he maybe his son is also wants to say something. If you listen his thoughts also, then you can give some sort of support, maybe some psychological support or counseling needed. You can support, you can connect them. So once you that explore their problems, then only you can support. So better you can do the individual assessment. Okay. Sometimes the family, the father will be blaming the son. Okay, he is not take care of me well because of his busy schedule. But okay, anything is there, so you can, at least you can do one thing. You can listen his problems first, and then you can listen the caregiver side also. Okay. Okay, so if no more questions there, we can wind up the session. Anybody wants to ask anything, any question or any clarification regarding this, the topics or case presentation, please ask now. Otherwise, we can wind up the session. Next day, we will discuss on constipation and intestinal obstruction. Okay. So now we have, today we have learned about nausea and vomiting. Always try to identify the cause and manage the underlying cause well. Try for the non-pharmacological management first, and then go for the pharmacological management. So when we assess it, you are, as I mentioned earlier, you have to do the proper assessment. If you do the proper assessment, better assessment, definitely you can able to plan well. So definitely that way we can improve the quality of life of the patient. Okay. Thank you, ma'am, for the